Okay, so next is the mesothelioma, which I already told you you're having a cancer in your pleura, right? And because the pleura is surrounding the lungs, so if you have a mesothelioma, does this cancer also surrounds my lung?
Yes.
So whenever you see a patient having a mesothelioma, on the gross appearance, it will be appear as the cancer surrounding the lung, like a pouch. Okay.
Okay.
Now these patients again will be having a history of progressive dyspnea, cough. Apart from that, the patient can also be having a pleural effusions, and these are again very much common because you're having a cancer in the pleura, right? Itself, so the patient can be having the pleural effusions also. On the chest X-ray, what you'll find is the nodules on the pleura, because this condition will start as a nodular appearance, right?
Right.
Apart from nodules, patient can also be having a diffuse thickening of a unilateral pleura. Okay, that is forming, with the plaque formations that is totally surrounding the lungs. So on the CT, you will find a very thickened pleura that is surrounding the lung like a pouch. That will found on the CT of the patient. Some nodules can be found on the, on this pleura also sometimes. Okay, and when you perform the biopsy of a patient, you will see some long filamentous cells, some long slender microvilli will be there, tone of filaments will be there, and these cells are joined by the desmosomes. Okay, well, this thing is again not very much important for you to remember, but they will just describe this feature in the histology of a patient. In the CV, they will describe these features. So, again, this will help you what kind of a cancer it is. Okay, so long slender microvilli will be seen, the tone of filaments will be seen, and all of these cells are joined by the desmosomes. Apart from that, patient will also be having a psammoma bodies in case of this mesothelioma. And what is a psammoma body?
Calcification.
Yeah, you will have a calcifications because of a hypoxic environment in the center of a cancer, right?
Yeah.
So these will form the psammoma bodies. When you perform some histological markers, what you will find is the patient is having a positive histology marker for the cytokeratin and the calretin. Okay, so these are the positive markers for the mesothelioma. Remember this condition also. The step one mainly asks you this fact. Okay, that what kind of a tumor markers this patient would be having. So this will be the calretin and the cytokeratin, or they can give you a patient having all these symptoms: dyspnea, dry cough, the pleural effusions. Apart from that, they will tell you the patient is also having a positive for calretin and cytokeratin, and now they want to diagnose you the condition. So it will again be a mesothelioma. Okay, and they will ask you what kind of a pleural effusion it could be. So these pleural effusions are always the hemorrhagic. Okay, most oftenly you will find these kind of effusions, they are hemorrhagic type. Okay, so a patient is having a hemorrhagic pleural effusions. You perform the X-ray, you will find nothing but just a complete whiteout, right? Because this fluid uh, uh, so just give me a second. So this hemorrhagic fluid which is present in your mesothelioma, in your pleura, this will obstruct the X-ray passage, right?
Right.
So again, a complete whiteout on the unilateral lung will be seen. So again, the findings that will be seen in a pleural effusion, similar findings will be there in case of mesothelioma also. And please note, smoking is not a risk factor for this cancer, but asbestosis is. Okay, and lung parenchyma is totally normal. It just this tumor is compressing your lung, as you can see, right?
Right.
So again, all these symptoms will be there. Any doubt on the mesothelioma?
Yes, please. How can we differentiate with asbestosis? We have both risk cancer for bronchogenic carcinoma and mesothelioma, right?
From yeah, you can have this, yes.
So how can we differentiate them?
See, if you're doing a biopsy of the lung and you find lesion there, okay, you find some cancerous cells in the biopsy of the lung, then you will say this could be a case of the bronchogenic carcinoma. If you're doing a biopsy in the pleura and you're finding the findings there of the cancer, then you will immediately know that this case is a mesothelioma, right?
Okay.
So they will mention you where the biopsy has been performed, in the lungs or in the pleura.
Okay.
Right?
Yes. Okay. With bronchogenic carcinoma, we have a pleural effusion.
Yeah, of course you can have pleural effusion in the bronchogenic carcinoma also, but the lesion will be more central, right? In the bronchogenic carcinoma. While in case of mesothelioma, these lesions are always peripheral.
Okay.
Again, CT will help you. If you perform a CT and you're seeing a bag-like appearance of the pleura, a thickened pleura surrounding all this lung diffusely, you can think about a mesothelioma again, right? So CT will be there, biopsy will be there, and many other things are again. If you're having a hemorrhagic type of effusion, you can again think about mesothelioma. You cannot have a hemorrhagic effusion in case of normal cancers, right? So these things will help you differentiating between the two. Okay.
Okay.
And now you have the acute respiratory distress syndrome. Whenever a patient who is totally normal an hour ago now suddenly develops a respiratory distress, dyspnea, chest pain, unable to breathe, breathlessness, all these things, suddenly you will call it a patient could be having a ARDS. It is just like the NRDS, but the NRDS happens in the neonates, right?
Right.
While the ARDS happens in the adults. Just like the NRDS, you'll be having a collapse, a diffuse collapse in the lung. And please note, this condition is not related with the heart failure. Okay. See, a very severe kind of a pneumonia, imagine a patient having a very severe kind of a pneumonia. Okay, he's having all this fluid inside the lungs, diffusely. All the alveoli are filled with the fluid. X-ray showing all these reticular opacities in the X-ray, right? You're having a respiratory failure suddenly. Okay. So this kind of a thing could be there in case of ARDS. But please note, the same thing could also be present in case of heart failure, right?
Right.
So if this edema thing happened because of a heart failure, you won't call it a ARDS. Okay. ARDS is totally different from that of heart failure. If the ARDS is happening because of a this heart failure condition, you won't call it ARDS then. Okay.
Yes.
Now, whenever you have an inflammation in the lungs, okay, that means whenever you're having any kind of alveolar insult, this will cause the release of cytokines by the neutrophils, by the macrophages, right?
Right.
Now, you also have a diffusion barrier, epithelium, basement membrane, and the endothelium, which is preventing the mixing of the contents of alveoli and the blood, right?
Right.
Because of the cytokines release and the neutrophil recruitment and the activation and release of other toxic materials, this membrane is now getting damaged. And when the membrane is got damaged, all of the blood, all of the fluid will be released into the alveoli now.
Right.
So you're having an increase in the vessel permeability that is causing a leakage of a protein-rich fluid inside the alveoli. And if this protein-rich fluid leaked inside the alveoli, can I have a membrane formation because of that thing?
Right.
So what you will find is these hyaline membrane in the alveoli. This is a complete alveoli, one alveoli, okay? And as you can see, all these bloods are present in the alveoli, and these are the hyaline membrane, a thickened membrane of the alveoli will be seen. And that's all because of a deposition of this protein-rich fluid on the surface of the alveoli, right?
Yes.
So the formation of intra-alveolar hyaline membrane will happen, okay? And the patient will got a non-cardiogenic, this word is very important, patient will get a non-cardiogenic pulmonary edema. So how can differentiate if the patient is having this edema because of a heart problem or maybe due to a primary lung problem? You have to perform the PCWP. Remember what is this PCWP?
Pulmonary capillary wedge pressure.
You measure what pressure in this PCWP?
Left atrial pressure.
You will measure the left atrial pressure, and if you find it elevated, that means some problem is with the with the heart only, right? And now you're having an edema in the lungs because of that. But if the PCWP is normal, that means your left side of heart is totally normal. That means the edema is happening because of some lung problem only, right? A primary lung problem is there. Yes.
Yes.
Yeah.
Now, because of release of all these, the cytokines and toxins and the leakage of this fluid, patient ultimately loses a surfactant. And when they loses a surfactant, patient will be having an alveolar collapse, right?
Yes.
So both the type 1 and the type 2 pneumocytes die in this condition. Okay. Patient will be having a loss of gaseous exchange. Patient will be having a loss of surfactant. Surfactant is not there. That means the compliance of the lung is also decreased now.
Yes.
So again, the compliance will be lost in my lungs. Now, causes could be anything. Anything that induces an inflammation in your body can cause the ARDS. For example, sepsis, which is the most common type. Aspirational pneumonia can cause it. Even a normal pneumonia can progress to the ARDS. A virus can do that. For example, this COVID virus, right? Most of the patients are dying because of ARDS, right?
Yes.
So any kind of an inflammation in your body can trigger this ARDS in the lungs. A trauma can do that. Pancreatitis can do that. So most oftenly, patient could be a sepsis patient or this trauma patient. You encounter a patient just having a trauma. Okay, he met with an accident. Now he's hospitalized, and now the patient is having a respiratory distress. You will think about the ARDS, right? While a patient who just have a trauma can also have the bleeding from multiple sites, multiple IV sites, and even having a respiratory distress. You will think about the DIC, right?
Right.
Because a traumatic patient can have the respiratory this distress in case of the DIC also, right? So if the bleeding is there from multiple sites, from non-injured sites, that means the distress is because of DIC. And again, this distress can progress to the ARDS also, right?
Right.
So these are the common causes of the ARDS. Now, when you encounter a patient having a sudden loss of respiratory function, having a sudden loss of, having a sudden shortness of the breath, dyspnea, chest pain, pleuritic type of chest pain, okay, then you perform the X-ray of a patient. And in the X-ray, what you will find is the bilateral lung involvement. Diffuse opacities will be found because, as you can see here, diffuse opacities are present, right?
Right.
Both the lungs are involved because this condition always involves both the lungs. Okay. Patient will be having a respiratory failure within a week of the alveolar insult. That means patient will be having a history of trauma. And now on the second day or third day, mainly it happens on the second or third day, the patient is hospitalized. And on second or third day, patient is suddenly develop this ARDS. So this condition must be happening within a week of the alveolar insult. Okay. Of course, you cannot inspire the air now, right?
Yes.
And ultimately, you will end up having a decreased PaO2 to FiO2 ratio because the oxygen in your blood is not decreased, right?
Yes.
Now, two things will also happen. Okay, patient will be having an intrapulmonary shunting, and it must be a right to left shunting, not a left to right shunting, right? Because the blood will always flow from left to right. Sorry, right to left, right?
Yes.
So this is the shunting. Second thing, daddy space can also be occurring. See, because because this is an inflammatory condition, at some places you will be having a damage of the vessels, and at some places you will be having a damage of alveoli, right?
Yeah.
So at the places where the damage of the blood vessels is happening, what you will find is a alveolar daddy space, right?
Yes.
Right.
You will have a microthrombi formations in the vessels because of this inflammation, because whenever you have an inflammation, you will also have an increase in the coagulability, right?
Yes.
So the platelet thrombi can be, all these microthrombi can be formed in the vessels, and when the microthrombi are formed, they will obstruct the blood flow to a particular this alveoli or a group of alveoli, right?
Yeah.
So
Right.
this can increase the dead space in the lungs. Secondly, because of our because of this fluid-filled alveoli, air cannot reach to the alveoli now, and as a result, patient will be having a shunting. The blood is there, but not the air, right?
Yes.
So shunting will be there, and this
To the space.
the dead space will be there. So two things will help. The two things will cause ultimately the hypoxemia. And what about the AA gradient? Would it increase or normal or decrease?
Increased.
Increase.
Yeah, it will be increased. Okay. Now, symptoms of this respiratory failure must not be due to the heart failure, and that is the only condition for this ARDS. Patient must be having a normal PCWP in order to diagnose this ARDS. Okay, so a patient having a shortness of breath hours or days after the damage has been occurred, hypoxemia, pulmonary edema, that means patient will be having a crackles, patient could be having a cyanosis, pleuritic chest pain could be there in the patient. When you perform the X-ray, you find this diffuse involvement of the lung suddenly. When you perform the biopsy, you can find these alveolar hyaline membranes, and that's how you know that the cause of this sudden loss of respiratory function in this patient is because of ARDS. Okay. So compliance of the lungs will be gone. Air exchange will be gone. Patient can develop the pulmonary hypertension because of that. Okay. So management, again, you have to treat the underlying cause. You have to treat the sepsis, pancreatitis, or maybe the trauma in the patient. Mechanical ventilation should be given, and because the airway is now collapsed, you have to give the patient PEEP therapy, right?
Yes.
Now, what kind of a disease is it? The restricted disease or an obstructed type of disease?
Restrictive.
Yeah, you will have all the findings of a restricted lung disease. Remember that also, okay? Loss of lung functions, loss of this functional vital capacity, loss of DLCO will be there, loss of residual volume will be there. The majority of the patients, because the stem cells are kind of preserved, so these patients will have a total recovery after the months, okay? It will take 2 to 3 months for the patient to recover, but after that patient will have 100% recovery. But some patients can also get a permanent fibrosis in lungs after this ARDS. Okay.
Okay.
So that's about the recovery thing. You have to remember, majority of the patients, they have a complete recovery because the stem cells are preserved. But minority of the patient can also develop permanent fibrosis because of loss of stem cells. Okay. Now, ARDS can also be happening in case of children. They will give you a patient who just drowned in the water, right? And after drowning, the patient can also have a ARDS because he have a fluid filled in the alveoli, right?
Yeah.
So drowning is also, again, you can include in the trauma. Okay, so drowning is again can cause the ARDS. Now, apart from that, patient can also have the injury in the lungs because of a radiation, right?
Yes.
Because whenever you give the radiotherapy or you give the patient radiation, you will have a free radical oxidations, right? That will damage the cell membrane, the proteins, and the DNA. Yes.
Yeah.
Because the cell damage is there, again, same cycle will happen. You will have a release of inflammatory mediators, neutrophils will be recruited, interleukin, the TNF alpha, TGF beta will be released. Okay, and ultimately in the acutely, patient again will be having a inflammation in the alveoli, which you call the alveolitis maybe. Hyaline membranes will be seen in the acutely patient. So dyspnea, shortness of breath, cough. On the auscultation, you'll find the crackles. All these things are present in the patient who just undergone a radiotherapy. For example, the radiotherapy for a breast cancer, right?
Right.
Now, after some time, after 2 or 3 months, either the patient got a recovery or this patient can develop a dense fibrosis in the lungs. Okay, and as a result, the patient will have the traction bronchiectasis could be there in the patient, fine crackles will be there, fibrosis, shortness of breath, unable to expand the lungs, shortness of breath, all these things will be there in the patient for the lifetime now, right?
Right.
So that's about the radiation-induced lung injury. Okay, remember this thing also. So two type of lungs, ARDS, and similar to ARDS, radiation-induced lung injury can also be happen because of radiotherapy or exposure to any kind of a radiation. Any doubt on this page?
Can you explain how AA gradient increase in this ARDS?
Because I told you at some places you're having alveoli, which are kind of normal, can still filled with the air, but you cannot exchange the gas now, right? Although this condition, this condition affecting your lungs completely, both the lungs, but not every alveoli is affected, right? Not every blood vessel is affected in the lungs. Okay, some areas are kind of normal again, some areas are affected. So those areas which are affected, there you can still exchange the air.
Yeah.
But the areas which are affected totally, you cannot exchange the air, and as a result, you will end up having a AA gradient.
Okay.
Okay.
But how it is increased rather than decreased?
Why would you have a decrease AA gradient?
Because the oxygen in alveoli is comparatively more than
See, alveoli is
in
filled with the alveoli are filled with the this blood or this fluid. I know, but still you can have some amount of air in the alveoli right now. Okay, some amount of air could still go in the alveoli also, right?
Yeah. Yeah. Right.
But this air cannot be exchanged now.
Okay.
Because of just thickened membrane and all these things, this air cannot be exchanged. So a small amount of air can still go in the alveoli, but can never be exchanged.
Okay.
That's how shunting and that's how the steady space, right?
Right.
So air is still there, but cannot exchange it. So again, you will end up having a high AA gradient.
Okay. Right.
Yeah.
Got it. Yeah, got it. Thanks.
At some places, normal AA gradient, at some places, increased AA gradient. But when you look at the overall condition of the lungs, you will find an increased AA gradient only, right?
Yeah, right.
Can I?
Any more doubt on, yeah?
Yes. Could it be unilateral or always bilateral?
Always bilateral. A
Both
diffuse lung
lungs.
injury must happen, yes. A diffuse lung injury must be happen, bilateral always.
Even in pneumonia cases?
In pneumonia cases, initially you have the pneumonia in the unilateral lung, maybe a lobe. But when this pneumonia becomes busy, pneumonia is a cause of ARDS. Pneumonia is not a ARDS, right? So when this pneumonia becomes
the
so much
trigger.
severe, when this pneumonia becomes so much severe and it involves the bilateral lung, you will call it ARDS.
Okay. Another question is, how can pancreatitis cause it?
Because it's an inflammatory condition again. In the pancreatitis, you're having inflammation. And I told you, any kind of inflammation can trigger this, right?
Yeah, there's not any relation for the pancreatic enzyme in the circulation, or
The enzymes, if they're released in the blood, it can damage anything then. But that's not what's happening in case of pancreatitis. It's just an inflammatory scenes. You're having a lots of interleukins in the blood. All these interleukins will ultimately reach your, these lungs. Because ultimately, this thing start with the pro-inflammatory cytokines, right?
okay, yes.
So you just need the cytokines in the blood. If the cytokines are in the blood, they will cause an injury to the lungs. They will cause a recruitment of neutrophils, and ultimately, you'll be having a damage of the alveoli now. And in case of pancreatitis, again, you will have a release of lots of these interleukins in the in the blood circulation. So they will reach to the lungs. They will recruit the neutrophils there, again causing the ARDS. Okay.
Okay. Our last question is, it causes respiratory failure, right? So how will be for recovery?
How would be for the recovery? Sorry, I understand this.
Since there is a respiratory failure, how the patient
Yes.
will recovery full recovery after it, and the prognosis? It will
You
not
give
be
the
life
patient first of all the
threatening.
mechanical. You give the patient mechanical ventilation, PEEP therapy. Okay. You keep them on the PEEP therapy for like days, for weeks, even for months until they recover totally. Right? Because the stem cells are kind of preserved now. Because the stem cells are still there, so they will recover completely, right? You will have regeneration.
Okay, thank
But
you.
if the stem cells are lost, then this recovery will happen with the fibrosis. Healing will occur with the fibrosis now, right?
Okay, thank you very much.
So any more doubt on the ARDS or the mesothelioma?
No, thank you.
Now you have the sleep apnea. And in the psychiatry lecture, we have discussed about the sleep apnea. Remember, I told you how to differentiate between a narcolepsy and the sleep apnea? You won't remember, right?
Narcolepsy will be having those hypnopompic and hypnagogic hallucinations.
Okay. Other thing, what about the kind of sleep? You would be having a sleep attacks in both the cases. Patients sleep
REM,
suddenly in the morning, in the,
yeah, REM latency will be decreased.
well, you cannot ask the patient about the REM latency, So you have to ask the patient, how does he feeling, his history taking, what you will find in the history taking that will suggest the narcolepsy, but not the sleep apnea.
Sudden loss of motor tone.
Okay, this could be present. I'm asking about just the sleep.
The patient will feel relaxed after having sleep in narcolepsy. But
Yeah. In case of narcolepsy, when they sleep, they feel typically refreshed, totally refreshed. In case of sleep apnea, because they have this obstruction in the sleep, many times they have this obstruction in sleep. So they will wake up in the night many times, and as a result, they have a very poor quality of sleep. And whenever they woke up after the sleeping, they will always be not refreshed, right?
Yes.
So that is a very important thing to differentiate between narcolepsy and sleep apnea. Step 1 might not give you all these hallucinations, all these, the loss of motor tone, but this thing, this refreshness or not refreshness, this will totally help you, in finding whether the patient is having sleep apnea or maybe having a narcolepsy. Okay.
Okay, yes.
The sleep apnea is mainly happens, the most common type is obstructive sleep apnea, and it happens because of obesity. What happens is patient will have a cessation of the breathing after 10 seconds, for more than 10 seconds. Okay. So what happens is they're sleeping normally, and suddenly they have a cessation of this breathing. And after 10 seconds, when the patient did not get the oxygen, he then suddenly woke up. Okay. And it happened multiple times in the night, even 50 or 100 times in the night. So they have a very disrupted sleep. And as a result, because they have a very poor quality of sleep, they will end up having a daytime somnolence, right? And they typically do not feel repressed, after the sleep, right?
Right.
Now, one more thing you need to know, that the voluntary breathing is always normal. In the daytime, when they breathe, their breathing is totally normal. It's just in the night time, because they are not conscious, only in that time they will have a cessation of the breathing. So even in the daytime, if you try to find this condition when they're not sleeping, you cannot diagnose it, right, properly, because they do not have any kind of a apnea in the daytime. In the night time, you have to monitor the patient, their cycle, and that's how patient is, this patient is having a sleep apnea, right?
Right.
The other thing is, because they're having this cessation of the breathing, that means they're not inhaling any oxygen in the lungs, right? In that period, right? So if they're not inhaling any oxygen, that means they're having a hypoxia in the lungs. And whenever you have a hypoxia in the lungs, what will happen then?
Pulmonary vasoconstriction.
Yeah, you will have a hypoxic pulmonary vasoconstriction, and as a result, these patients will also having a pulmonary hypertension, right? And this pulmonary hypertension can even induce the arrhythmias, because they will unnecessarily put a pressure on your atrias, right?
Right.
And I told you, whenever you have a change in the heart, any kind of a change, this can promote the arrhythmias in the heart, right?
Right.
So AFib flutter can also happen in the patients, and that can also happen in these patients. Because of a chronic hypoxia throughout the bodies, the kidney will release the EPO, and this will again cause the erythropoiesis. These patients will also have a high hematocrit. Okay. Now, 3 types are there. One is the obstructive sleep apnea. Second is the central sleep apnea. And third is kind of a sleep apnea, which is the obesity hypoventilation syndrome. Okay. Now, in case of obstructive sleep apnea, because of a very narrow respiratory passage and your oral cavity, because it is filled with the fat and all these tissue, okay, so you have a very small passage for the air. In the night time, because of this obesity, okay, patient again will be having a cessation of breathing for more than 10 seconds. So if I want to draw the graph, remember this graph I told you for the myasthenia gravis?
Yes.
See, as you can see, in this case, a diaphragmatic activity is totally normal, right?
Yeah.
The muscles are contracting normally. But as you can see, the airflow is there for some time. After that, the airflow is totally ceased. Then again, at that time, when the 10 seconds occur, the patient will get woke up from the sleep, right?
Right.
Then they again respire. Then again, same thing, after some time, cessation of breathing. Then patient again woke up. Then they again breathing. So as you can see, the diaphragm is continuously working. It's just the air is not going into the lungs, right? And that thing will suggest you the patient could be having a obstructive sleep apnea. Okay. While in case of a central sleep apnea, that may be happen with the heart failure or maybe with the herniation in the brain. Okay. You will have a loss of motor function also. So sometimes you have a normal motor function, as you can see, the muscles are contracting, but then again, muscle will stop contracting, and at that time, you will get the apnea. Patient again woke up, same contraction period, same apnea again, right?
Yes.
So if the nerves are working properly, muscles are working properly, but you're not getting oxygenation, that means obstructive sleep apnea. If the nerves are not working, muscles are not working, and that only you're having this apnea, that means it is a case of central sleep apnea. Okay.
Yes.
Now, so these patients will be having obesity. Of course, the BMI is always kind of more than 30 in these patients, because only after a severe type of obesity patient can have this the OSA. So Stephen will also mention, somewhere the BMI is more than 30. And that again will give you a super hint that this could be a case of sleep apnea. Okay. Loud snoring history would be present. Daytime sleepiness will be present. Okay. And these patients, excessive pharyngeal tissue is blocking the airway. Okay. In adults, in children, the tonsillar hypertrophy can again block this passage and again can promote the OSA in the patient. Patient will be having a morning headache, and these patients typically do not feel refreshed after waking up. Okay. Central sleep apnea, it will happen whenever you got a CNS injury, that means could be a hernia, or whenever you get a heart failure, or it can also happen with the opioid usage. Okay, you will get a change stroke aspiration, which we will discuss. These are the change stroke aspiration. Okay, one time you will get the normal these nerves, normal muscle, and normal breathing. Then for some time, the nerve stop working, the muscle stop working, and you will get a period of apnea. Okay. So this kind of a cycle will be seen in these patients, importantly. Okay. So you have to treat this condition by giving the patient positive air pressure again. You have to forcefully open these pressures so you can give the oxygenation there directly. Now, third one is the obesity hypoventilation syndrome. Only see, in both of these conditions, you will have a hypoxia in the nighttime, or you can say a hypercapnia in the nighttime, right?
Yes.
While in the daytime, the oxygen levels and the CO2 levels are totally normal. In case of obesity hypoventilation syndrome, you will be having an elevated CO2 levels after even waking up. Okay, so because of a hypoventilation, which we have discussed previously also, the patient cannot inspire the air because of so much, this tissue over the chest. Okay, the patient will be having a restricted lung symptoms. Patient will be having a very high PaCO2 during the waking hours even. Okay, decreased PaO2 and increased PaCO2 during the sleep will happen in these patients. Okay, and what about the AA gradient?
Normal.
Normal. You will have a normal AA gradient in case of obesity hypoventilation syndrome, because this condition is not affecting the lungs, right? It's just your lungs cannot expand because of presence of so much tissue, so you cannot inspire the air at all. Okay.
Yes.
So that was about these type of apneas. Any doubt?
Can you explain how there is increased PaCO2 while everything is normal? Like the function of the lung is normal.
If you cannot inspire the air, then you cannot exchange the airs, right?
Right.
And if you do not do the breathing properly, if you're doing the hypoventilation, see, you're doing the hypoventilation, the breathing rate is decreasing, right?
Yeah.
So if your breathing is decreasing, you cannot exchange the air properly, and you need to eliminate the CO2 from the body, right? For doing that, you need to increase the breathing rate of the patient.
Okay.
So if the patient is not breathing properly, if he's having very shallow breathing, very less breathing, very slow breathing, then he cannot exchange the air properly. If he cannot exchange the air properly, he will end up having the high CO2 levels in the blood.
Right. Is there anything linked to like perfusion limitation in PaCO2? Is
You're
there
also having a
any?
hypoxic visualization, you're asking?
I'm asking in context with perfusion limitation of CO2 as a guess.
Perfusion limitation.
Like we have discussed that CO2
Yeah,
will.
I know about this perfusion limitation. See, you're also having a hypoxic vasoconstriction, so this could also promote this condition. But ultimately, because of this low breathing rate only, because if you're not having a breathing properly, you cannot exchange the gases then, right?
Yeah.
Because in order to excrete the CO2 out of your lungs, out of your body, you need to expire properly, right?
Right. Yeah.
So if you're not expiring properly, then no matter how much gas you exchange in the lungs, it will,
Stay in the
they will
lung.
always stay in the lungs, right?
Right. Okay.
That is the thing.
Yeah. Thank you so much.
Any more doubt on the sleep apneas?
No, thank you.
The presentation of the sleep apnea is very simple. You will get a patient who is having a very high obesity. He's having a very high CO2. He will be having, the loss of sleep in the nighttime, snoring, not freshened, headache, and all these things. You will immediately know that this patient must be having a sleep apnea. Okay, when you encounter such patients. The main thing Stefan can ask you about this hypoxia, about this hypoxic vasoconstriction, right-sided heart failure, arrhythmias. They can ask you about these graphs. Would that I show you? Would they can ask you about these graphs also, right? So these are the main things that you will look for in these patients. I think we should take a short break and then continue with the pulmonary hypertension.
Okay.
I will again start the new session, okay? Because it's going to expire after 3 minutes.
Yes. Okay.